So about fertilization, only a tiny fraction of few hundred out of millions of sperm reach the fallopian tube's ampulla, the usual site of fertilization. Sperm must undergo capacitation, the biochemical changes enabling fertilization, within the female reproductive tract, followed by the acrosome reaction to penetrate the zona pellucida. Crucially, after one sperm fuses with the oocyte membrane, the zona reaction occurs, biochemically hardening the zona pellucida and inactivating sperm receptors to prevent polyspermy, fertilization by multiple sperm, which is of course lethal. What is clinical importance, my beloveds? Issues with sperm motility, capacitation, acrosome reaction, or oocyte quality can prevent fertilization. Blocked fallopian tube prevents sperm and egg from meeting. Assisted reproductive technologies, techniques like IVF, that is in vitro fertilization, bypass natural barriers by mixing sperm and egg in vitro. Intracystoplasmic sperm injection directly injects a single injects a single sperm into the oocyte, overcoming severe male factor infertility or fertilization failure. Ectopic pregnancy, so we will talk by the grace of God about that. So understanding that fertilization normally occurs in the ampulla helps explain why tubal damage, for example, pelvic inflammatory disease or surgery, increases the risk of ectopic pregnancy, where the embryo implants outside the uterus, most commonly in the fallopian tube. But normally it occurs in ampulla. So next, the morula stage involves compaction, making the first cellular differentiation. As the zygote undergoes cleavage, rapid cell division without overall growth, it forms a morula, a solid ball of 1632 cells. Around this stage, the outer cells flatten from tight junctions and begin to seal off the inner cells, a process called compaction. This is the first morphological sign of differentiation, establishing distinct outer, that is future trophoblast, and the inner, future renal cell mass, cell populations. Early blastomers, means cells up to the 8-cell stage, are typically considered totipotent, capable of forming a complete embryo and placenta. Clinical importance: pre-implantation genetic testing, PGT, PGTA, pre-implantation genetic testing for aneuploidy, or PGTM, pre-implantation genetic testing for monogenic single-gene disorders, often involves biopsying one of the few cells from the blastocyte stage, specifically the trophectoderm, if I pronounce correctly, trophectoderm. So relying on the understanding that these outer cells are representative, with caveats for mosaicism, their removal doesn't necessarily compromise the inner cell mass developing into the fetus. The concept of totipotency, pluripotency, underpins this. Embryo development in in vitro fertilization, assessing morula quality and compaction is part of grading embryos for transfer in vitro fertilization cycles. Poor compaction can indicate lower development potential. Implantation requires a synchronized dialogue with a narrow window. Implantation isn't just the blastocyst sticking into the wall. If an active complex processing requiring molecular dialogue between the blastocyst trophoblast and the receptive uterine endometrium lining. The endometrium is only receptive for a short period, known as the window of implantation. Typically days 20-24 if we take 28-day cycle, regulated by ovarian hormones, progesterone. The trophoblast actively invades the endometrium using enzymes like metalloproteinases, similar to invasive tumor cells but highly regulated. Clinical issue. So, clinical importance is that this is a major cause of early pregnancy loss and in vitro fertilization failure. It can result from embryonic factors, for example, chromosomal abnormalities or uterine factors, for example, unreceptive endometrium due to hormonal imbalance, inflammation, polyps, fibroids, or thin lining. Ectopic pregnancy. If implantation occurs outside the receptive endometrium, for example, fallopian tube, cervix, ovary, abdomen, it leads to dangerous ectopic pregnancy. I repeat, by the grace of God, we will talk about that. Recurrent pregnancy loss. So investigating uterine receptivity issues is part of the working for recurrent pregnancy loss. Contraception, some hormonal contraceptives. And we know that. The trophoblast, the embryos, invasive. So actually the trophoblast, yes, very interesting point. That the trophoblast is the embryo's invasive forces. Special forces, and first endocrine organ. The trophoblast differentiates into two layers, the inner cytotrophoblast, cellular, and the outer syncytial trophoblast. Sorry for my pronunciation. So a multinucleated syncytium formed by cell fusion. The syncytial trophoblast is highly invasive, eroding maternal tissues, endometrium, and blood vessels to establish placental circulation. It's also the primary source of human chorionic gonadotropin, HCG. The hormone detected in pregnancy tests, which maintains the corpus ileum in the ovary to continue progesterone production, essential for early pregnancy maintenance. Clinical importance. So detection of HCG in urine or serum confirms pregnancy. Serial HCG levels help monitor early pregnancy viability, normally doubling every 48-72 hours. Abnormally low or plateauing levels suggest miscarriage or ectopic pregnancy. Very high levels can indicate multiple gestation or gestational trophoblastic disease. Actually, about gestational trophoblastic disease, I have no idea. By the grace of God, maybe we'll talk about that, but in few words. The spectrum includes hydatidiform molar pregnancy and choriocarcinoma, characterized by abnormal proliferation of trophoblastic tissue. Maybe it's a choriocarcinoma to pronounce. Choriocarcinoma, up to you to how to pronounce. Monitoring HCG levels is crucial for diagnosis, treatment response, and surveillance for malignancy. And preeclampsia pathophysiology. Defective trophoblast invasion or remodeling of maternal spiral arteries are implicated in the pathogenesis of preeclampsia, leading to reduced placental perfusion and maternal hypertension and organ damage. Chorionic villi and functional units of the placenta with fetal organs. So the chorion derived from the trophoblast and extraembryonic mesoderm develops finger-like projections called chorionic villi. These villi branch extensively, creating an enormous surface area, equivalent to the tennis court by term, for nutrient, gas, and waste exchange between maternal and fetal blood. Importantly, the fetal capillaries within the villi are separated from maternal blood in the intervillous spaces by the villous barrier. Syncytial trophoblast, cytotrophoblast, connective tissue, capillary endothelium, fetal and maternal blood do not normally mix. What is clinical importance? So we've got a chorionic villous sampling, CVS, sampling, chorionic villous sampling, sampling. This pregenital diagnostic procedure involves obtaining a smaller sample of chorionic villi, fetal genetic material, typically between 10 and 13 weeks gestation for genetic testing, karyotyping specific gen mutations, no changes, mutations. It allows earlier diagnosis that amniocentesis, but carries a slightly higher risk of procedure-related miscarriage. Slightly. Risk of procedure-related miscarriage. Placental function and insufficiency. The development and health of chorionic villi are critical for fetal growth. Conditions affecting villi structure or perfusion, for example, maternal vascular disease, infections, thrombophilias, can lead to placental insufficiency, resulting in intrauterine growth restriction or fetal distress. Then, rhesus isoimmunization. Although blood doesn't normally mix, small fetal-maternal hemorrhage can occur, especially during delivery, trauma, or procedures like chorionic villus sampling or amniocentesis. Potentially exposes an rhesus factor negative mother to rhesus positive fetal red blood cells, leading to sensitization. About the inner cell mass, ICM, that the inner cell mass gives rise to an entire embryo proper. While the trophoblast forms the placenta, the distinct cluster of cells inside the blastocysts, the inner cell mass, is the source of all tissues of the embryo itself. These cells are pluripotent, meaning they can differentiate into any cell type of the three primary germ layers, ectoderm, mesoderm, endoderm, which subsequently form all organs and tissues. But they cannot form the placenta or supporting membranes. Embryonic stem cells are derived from the inner cell mass. What is clinical importance? Congenital anomalies, errors in the proliferation, migration of or differentiation of inner cell mass, derivatives during intercell mass derivatives, during gastrulation and organogenesis lead to structural birth defects. Understanding these origins helps classify anomalies and predict associated problems, so-called Vacteral association is acronym. V is vertebral defects, A anal artesia, C cardiac defects, T tracheoesophageal fistula, renal anomalies, and L limb abnormalities, involves defects potentially arising from mesodermal issues. Teratomas, germ cell tumors, particularly teratomas, which can contain tissues from all three germ layers like hair, teeth, muscles, are thought to arise from pluripotent cells. Sarcococcygeal teratomas, for instance, can originate from remnants of the primitive stick derived from this inner cell mass epiblast. Then stem cell research. The pluripotent of this ICM derived embryonic stem cells holds immense promise for regenerative medicine, though huge ethical considerations are significant. No, not today about that. Placenta acts as a multiple organ simultaneously. The major placental functions as the fetal lungs, gas exchange, kidneys, waste removal, and gut, nutrient absorption, endocrine gland, producing hormones like progesterone, estrogens, HPL, human placental lactogen, HCG, relaxin, and immunomodulator, preventing maternal rejection of the semi-allogenic fetus. It actively transport nutrients like glucose and amino acids, facilitates diffusion of gases, and transfers maternal antibodies, immunoglobulin G, providing passive immunity to the fetus. What is clinical importance, my beloveds? Placental insufficiency, failure of any placental function, for example, nutrient transport, gas exchange, leads to problems, fetal hypoxia, potential long-term health consequences of the child. Doppler ultrasound assessment of umbilical artery flow reflects placental resistance and function. Endocrine function and maternal adaptation. So placental hormones are crucial for maintaining pregnancy and adapting maternal physiology. For example, HPL, human placental lactogen, contributes to insulin resistance, potentially leading to GDM, gestational diabetes mellitus. Progesterone maintains uterine quiescence. Huge problem, a very interesting point. Then, maternal infections. The placenta is a barrier, but not impermeable. Impermeable, not impermeable. Impermeable, I suppose in English. Pathogens like Listeria, Toxoplasma, Rubella, cytomegalovirus, and Zika virus can cross the placenta, so-called torch infections. This actually will be asked about that. Torch infections, toxoplasmosis, other agents, rubella, cytomegalovirus, herpes simplex, causing congenital severe diseases. God forbid. Drug transfer. Most drugs taken by the mother cross the placenta, necessitating careful consideration, very careful, of medication safety during pregnancy. For example, teratogenic drugs. Huge problem. Amniotic fluid volume is dynamic. About amniotic fluid, my beloveds. Amniotic fluid is dynamic and reflects fetal well-being. Amniotic fluid, initially derived from the maternal plasma, is later primarily produced by fetal urine output and lung secretions, and balanced by fetal swallowing. It cushions the fetus, allows movement essential for musculoskeletal development, prevents cord compression, maintains temperature, and plays a role in lung maturation. Fetus breathes fluid. Its volume changes throughout gestation, peaking around 34 weeks. What is clinical importance? We know the phenomena like oligohydramnios, low fluid, can indicate fetal renal problems, for example, renal agenesis, obstruction, placental insufficiency, or PROM, so-called premature rupture of membrane, PRIOM, PROM, is acronym, premature rupture of membranes. Consequences include pulmonary hypoplasia, limb contractures, Potter sequence, and cord compression risk. Polyhydramnios, high fluid. So oligohydramnios, this is a polyhydramnios, high fluid. Can be associated with fetal anomalies impairing swallowing, for example, gastrointestinal obstruction and anencephaly, maternal diabetes, fetal polyuria, multiple gestations, or idiopathic. No, idiopathic. I suppose idiopathic is more correct. Is correct. Consequences include preterm labor, uterine overdistension, cord prolapse upon membrane rupture, and maternal respiratory discomfort. Amniocentesis. Sampling amniotic fluid allows for genetic testing, karyotype, specific mutations from sloughed fetal cells, assessment of fetal lung maturity, LS ratio, lecithin, sphingomyelin ratio, and infection diagnosis. The umbilical cord contains fetal lifelines protected by so-called Wharton's jelly. The umbilical cord typically contains two umbilical arteries carrying deoxygenated blood and waste products away from the fetus to the placenta, and one umbilical vein carrying oxygenating blood and nutrients to the fetus from the placenta. These vessels are embedded in Wharton's jelly, a gelatinous substance that protects them from compression and kinking. What is clinical importance? Single umbilical artery, the phenomenon of SUA, it's acronym, SUA, single umbilical artery, finding two vessels, finding only two vessels, one artery, one vein, occurs in around 1% of cases. Sorry, it was urgent. So finding only two vessels, one artery and one vein, occurs in around 1% of pregnancy, while often as isolated and benign. It's associated with an increased risk of congenital anomalies, especially cardiac and renal. Aneuploidy, warranted detailed fetal anatomical survey. IUGR also, yes. Cord accidents, true nodes, nuchal nodes around the neck, nuchal, I don't know how to pronounce, nuchal or nuchal cords, or cord prolapse, Cord precedes the fetus during labor delivery, can compress vessels leading to fetal hypoxia, distress, or demise. Cord prolapse in an obstetric emergency requiring immediate delivery. DCC, delayed cord clamping, my beloveds, allowing placental transfusion to the newborn for 1-3 minutes after birth, improves iron stores and reduces anemia. Now recommended for healthy term and preterm infants. Cord blood banking, we've got. Umbilical cord blood is a rich source of hematopoietic stem cells which can be collected at birth and stored for potential future therapeutic use, for example, treating leukemia, certain genetic disorders. Here also we have several medical ethics issues. So next, so-called maternal-fetal interface as an immunological paradox. Yes, it's an immunological paradox. The fetus is a semi-allogenic, inheriting half its antigens from the father, of course, and yet the mother's immune system typically tolerates it throughout pregnancy. This involves some complex mechanisms at the placental interface, including downregulation of classical major histocompatibility complex, MHC, class I molecules on trophoblast cells, expression of non-classical HLA-G, human leukocyte antigen G, inhibiting maternal natural killer NK cells, local production of immunosuppressive factors like IDO, idoleamine 2,3 dioxygenase, idoleamine or idoleamine 2,3 dioxygenase, and shift towards T2, T helper 2 type immunity. The decidua also plays a crucial role with specialized immune cell populations like decidual natural killer cells. Clinical importance of that. So recurrent pregnancy loss, immune dysregulation, for example, autoimmune conditions like APS, antiphospholipid syndrome, or autoimmune factors where maternal immune rejection might play a role, is investigated as a potential cause of RPL, recurrent pregnancy loss. It's a very interesting point. Preeclampsia, we used to talk about that, now increasingly understood as a potential involving maladaptive maternal immune response to placental fetal antigens alongside poor vascular remodeling. Actually, there are a lot of questions around this point, but anyway. Infections in pregnancy. So, my beloveds, the altered immune system state So the altered immune So the altered immune states can increase maternal susceptibility to certain infections, for example, listeria, influenza complications, while potentially suppressing others. This is about infections. So actually, obstetric complications that you will be asked in big exams, understanding these tolerance mechanisms is key to developing therapies for immune-mediated pregnancy complications. That's all I want to talk about. Largely sufficient for this misunderstood questions on big exams. I don't actually think that you will be asked in this manner, but you have to know this topic. Very interesting topic. Very interesting topic. God is incredible. He's awesome. That's why it's created so beautiful, so complex. Fertilization, pregnancy, etc., etc. The actual nature created by God is actually fantastic. My beloveds, God bless you. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as don't forget to follow and subscribe my Telegram, Dr. Y Telegram channel. So Dr. Y, W-H-Y, W-H-Y. So Dr. Y, it's me. So you type in searching mode in Telegram, Dr. Y, W-H-Y, without question mark. Just Dr. W-H-Y. You find this in Telegram. You click start and you choose your plan. You will find a lot of interesting things. Videos, your MCQ tests, questions, answer, explanations in each domain. In gynecology, in internal medicine, my internal medicine, surgery, and so on. Presents, gifts, students' cheat sheets, and like this. So, stay blessed. Thanks for your attention.